Hello and welcome to the Pain Options Education channel. I'd be Darren.
And I'd be Tim.
This is the second in our ongoing series, the Pelvis series. Today we're talking about breaking down sacroiliac joint assessment paradigms. This is part of a larger series that we're doing just to really help clinical reasoning around managing pelvic girdle pain and problems with the pelvis. This is a slide to start with just to look at some trauma in the pelvis. This is actually a girl that got hit on her bike by a car. And we can see a number of fractures in this nice scan, fractures through the pubic bone, fractures through the ilium, looks like one of the transverse processes is fractured, so some significant trauma. But we could also notice that the sacroiliac joint there seems quite together and tight and almost happy amongst the chaos.
So that's the left side of the pelvis there, or the right side of the picture as you're looking at it, and they're significant fractures, so that really only happens in significant high speed or high impact trauma.
Yeah, and it does show you what happens to the pelvis when significant force goes through there, that the bone tends to fail before the joint.
And I remember doing our anatomy classes, and there was dissections there around the pelvis, and the ligaments around the pelvis are extremely extensive and strong, and then I guess that's supported by that effect from that trauma.
Exactly. Yeah. So I think this is a good thing to reflect on as we continue through this discussion today. Tim, I've put this in because I know it's your favourite slide. Can you tell me,
sure.
Do you see that moving?
Yeah, well, it is my favourite slide of circles. If you choose to pick and look at one of the circles, so focus on one, and then you'll notice that circle tends to stay still and the other circles tend to still move. You getting that when you look at it?
Yes, and then my eyes are darting around.
Yeah, but then if you then focus on another circle and keep looking at that, then now the other circles are moving, including the one that was still before. So to me, that summarises a few things about seeing what we want to see around the pelvis.
Well, let's see what we do know about the pelvis and how it aligns to that. Really, there's probably these three global ways to break down physical assessment of the pelvis. Particularly, we're talking about the sacroiliac joints here and trying to think of a clinician trying to decide whether the sacroiliac joint's involved in someone's presentation or not. So the three of them are written here: movement kind of based paradigms, positional fault paradigms, and pain provocation paradigms. Certainly, there will be people that use all of these elements within an assessment, but in terms of talking about it, this is a neat way to kind of break it down. So we'll start with movement. Does the pelvis move, Tim?
Very little.
It does move a little bit. Yes. Yeah. So when we talk about this, we really just want to talk about the gold standard of measurement. So the gold standard for any joint measurement is called radiostereometric analysis, RSA for short, and that is where you take tiny ball bearings and put them on either side of a joint. So in the case of the pelvis, the volunteer will have these ball bearings actually injected into the sacrum and some injected into the ilium. Then they set up two X-ray machines kind of at 90 degrees like this, and you get a 3D representation of the pelvis. It's extremely accurate. We're talking 0.2 of a degrees and 0.2 millimeters, so it's a gold standard.
Yeah, and so there's been a few studies that have used that.
Yeah, there has a kind of series of studies. Yeah. And I guess the summary of that is that when you're lying down, if you put maximum torsion through the pelvis, you might get an average around 2.5 degrees rotation in normals. And I kind of go like this, but actually the whole pelvis tends to move as a unit, not the individual joints.
So torsion would mean, I guess, pulling one leg up and keeping the other one down. So through hip flexion and extension on the other side. Yep.
And that number actually fits with what they find in the cadaver studies, so that's a good kind of external validation in a way. And then, but if you stand somebody up and kind of replicate the same thing, you get much less movement. We're talking maybe half a degree. Really fits with the idea that the pelvis needs to, the sacroiliac joint needs to be stable to transfer load during standing.
So that's bugger all movement. I was doing some home handyman woodwork on the weekend.
Yes.
And
that's why you still got the paints on your hand too.
Yeah, correct. I was using a miter box to cut some 45-degree angles, and even using that to line me up, they still weren't quite resting symmetrically there. So a couple of degrees out there can make a difference, but visually they looked fine to me. So we have to keep that size of movement or magnitude of movement in mind.
Good analogy. And then, the essence of the author's conclusions around those kind of studies, that if you're trying to palpate that movement, particularly in weight bearing, you've got no chance. They have done a series where they looked at people with pain and without pain, and the essence of that also is that it's not clear that there's an increase in the average movement in those with pain versus those that don't have it.
So essentially, we can't as clinicians detect movement or changes of movement in the sacroiliac joint. Is that fair to say?
I think that is fair to say. And also, it's very questionable if there's actually any changes in movement in people that do have symptoms from that area.
A couple of other thoughts that people might come up with around that. I mean, there's different studies that do show that, but they use other markers like skin markers. And there's obviously increased error potential with those. So measurement error. Just error?
Just error.
So that would be one part of it. And I guess the other common one would say, but what about in pregnant women or postpartum women, where we talk about sacroiliac joint pain and movement during childbirth?
And clearly the pelvis has to expand during childbirth to allow the baby to go through the pelvic canal. It does come to the stories of hormones, which we'll speak to a little bit later in this talk.
But could we say, but when I've got my pregnant patients, there's heaps more movement in their pelvises? Maybe,
but I guess if we in pregnant women, you don't usually put ball bearings in them and X-ray them. It's just not considered a good idea. But what you can do is measure the movement at the symphysis using ultrasound, so far less invasive. So there was a study that's looked at that and kind of looked at non-pregnant women, pregnant women with pain, and pregnant women without pain. Something like that.
Let's run with that.
No, let's not. It's people with normal movement during pregnancy and much more movement during pregnancy.
Right.
And basically the incidence of pain in those groups is the same. So there's not a clear relationship between increased movement in the symphysis and the amount of debilitating pain that someone might have. So you could kind of argue that it probably follows for the sacroiliac joints as well.
Okay. So for some people there is increased movement.
Yes.
But at the symphysis, but it doesn't necessarily correlate with pain.
So those people with increased movement can have pain, but so can those that don't have that significant increase.
Okay. Good. I think I'm clear.
Well, we tangled that one, but okay. So really, in summary of that, if you look at the validity of assessing movement and whether it's actually even something that occurs in these people in the sacroiliac joints, it's very doubtful that that's something you can do, and B, it's even an issue. And then when you look at the reliability assessment around those kind of tests, it's poor.
So that's almost a moot point if we can't measure it in the amount of movement small anyway.
Well, it's confirmatory, isn't it? Like that, what are you assessing? So good. So I like this picture here. So there is one other way of measuring sacroiliac joint movement that might hold up to the RSA studies, the ball bearings, and that is putting K wires, as you can see here, into the pelvis, so into the sacrum and the ilium, and watching how much the movement you get between the K wires.
Okay. So we'd be looking for a few volunteers if we're going to continue that type of research, would we?
We would. Interestingly, that study came up with similar numbers to the ball bearing studies. So. Okay, positional faults. So really there is one study that has looked at this in detail using the gold standard of RSA.
Yep.
So Tolberg and his colleagues took people, assessed them, and said, you have an upslope, you have a downslope, you have an outflare, some kind of positional fault. Then they put the ball bearings into the pelvis and took a very accurate picture of their pelvis and got the position of it exactly. And then they took the person and treated them to correct the positional fault that they'd assessed. So the treatment could have been anything that was appropriate for that, muscle energy, manipulation, whatever. And they stood the patients up and reassessed them and said, yep, we've fixed your outflare, inflare, upslope. And then they put them back in the X-ray machine and repositioned and reassessed their position of their sacroiliac joint using the RSA. And can you guess what they found, Tim?
Given there's hardly any movement in the first place, I dare say nothing much had changed.
No, nothing had changed, nothing at all.
Yeah.
So it really is very difficult to consider positional faults as an actual thing in light of that study.
And that study's not new, is it? It's 20 odd
1998,
years ago.
I think.
Yeah. So I think we accepted that and moved on a while ago. But the counter argument I hear from people is, but those techniques work. I apply that assessment to my patients, I detect those positional faults, and I apply my treatment, a reassessment, and I see the change on reassessment, and my patient gets better.
Yeah.
How do you answer that?
Yeah, I think it is true that those treatments work, and we should all know that manual therapy is a very powerful thing for changing pain and for changing muscle function in an immediate sense. So there's no doubt that you can apply a technique to the pelvis and get those effects on pain and muscle tone potentially. And certainly that's what the authors of the Tolberg paper suggested, that you're looking at neurophysiological changes, not hands-on changes.
Yeah, or other mechanisms beyond
other
neurophysiological.
Non-specific mechanisms of manual therapy.
So the treatments work in some patients because there has been studies to show that there is some beneficial effect from these treatments targeting positional faults. But it's not because you're addressing positional faults.
Correct.
Is that fair to say?
That is fair to say. And I really like to say, look, we're not telling people to throw these techniques away. They're still valuable. If your goal is to reduce pain so then you can do something else, they're clearly valuable in that circumstance. The problem we find is the beliefs that this can set off in patients, particularly around having an unstable pelvis. You know, they can't lift their baby because their pelvis will go out. They can't walk the dog because it'll pull on the leash and make their pelvis go out. So they start to avoid things, become fear avoidant. They become dependent on passive management. And there's only one place these people really get these kind of beliefs from, and that's therapists.
And I've seen, and you've seen many examples of that, where there's a negative outcome and people may say, yeah, but I don't do that with my patients. But we see this all the time, don't we? Where we deliver something that we can clearly understand what we're saying and we think people are taking it on board, but they may interpret that differently. So what do? We say the treatment techniques themselves may be effective, but you're not correcting positional faults. And you'd need to be very careful around your language, around using positional faults even at all with patients.
Yeah, absolutely. I wouldn't bring it up.
Yeah. Good. I agree.
Good. Anything else on positional faults? So in summary, the existence of positional faults is extremely doubtful. I'd be very happy for someone to put ball bearings in a series of people and see if they could, prove Tolberg wrong, but good luck to you on that one. And also then when you look at the reliability of the test for positional faults, again, they come up very poorly.
I can think of one example in 25 years, and that's someone in a truck accident where there was actual separation of the sacroiliac joint, clearly identifiable on their radiology, where you could arguably say maybe there was an issue there around stability, but that's one in a lot of patients.
Yeah, exactly. And I can think of one was a crush injury between a boat and a jetty, and it was a similar. So, but again, there's significant trauma there, and
sure, it's a different course of management and assessment there, isn't it?
Yeah. Not picking up your child or something like that. Yeah. Great. I've just thrown this in because this is a picture of the manipulation technique frequently described as a sacroiliac joint manipulation. What do you think that's manipulating, Tim?
Well, a range of things potentially. I certainly got taught that and used to have a go at that at times down the footy club and with my mates and with a few patients, and people often felt a crack, and it could happen anywhere from the thoracic spine down, I think, from my experience.
Yeah. Did you perform any of those manipulations on the bar, Tim?
Possibly.
All right, pain provocation. So there's a series of tests to assess pain provocation, and really this is the work of Laslett, who's looked at this in the most detail. For the movement and positional faults, we spoke of the gold standard of RSA. For pain, there's not a gold standard. The best we have is double-blinded injections. So a lot of studies have used those in the sacroiliac joints, and a lot more have just used single injections. But yes, there's not the gold standard of RSA for pain. So what Laslett's done has looked at a collection of tests, really, and but not those tests in isolation so much as more of a clinical reasoning paradigm. So one is that the area of pain is primarily over the sacroiliac joint, and we'll talk more about that in our subjective assessment episode. And then the second thing is that they clear the lumbar spine. So being from New Zealand, they use a Mackenzie method to do that, but I think practically you can clear the lumbar spine however you would clear it. And once you've filled those criteria, then you move to these pain provocation tests, of which there's 5. We won't go into detail about them now because we're going to demonstrate them again in another episode. But so he's taken this paradigm and assessed that against double-blinded joint injections, and essentially found if you fill those first 2 criteria of area of symptoms, clear the lumbar spine, and then have 3 out of 5 positive pain provocation tests, then there's a reasonable alignment between that and the injections.
Okay. So really, if you're going to try and say a person's got sacroiliac joint pain, this pain provocation testing, along with the other things you've mentioned, is one of the key criteria for determining is this problem coming from their sacroiliac joint?
Yes. Yeah, absolutely.
So being skilled, effective at screening out other structures and determining if using these tests the SIJ is involved or not goes a long way to making you more effective in managing these patients, I'd say. Yeah,
absolutely. And identifying the source of symptoms as much as you can with any musculoskeletal disorder.
If that's relevant for the individual patient.
Yeah. And it does remind me of my story of that patient that fell down the stairs, was diagnosed with a hamstring strain initially, went on to recover from that but still had pain, underwent 5 separate occasions of lumbar injections with no effect. And then when we assessed him, the lumbar spine was clear and the sacroiliac joint was clearly, based on that paradigm we've just described, the source of symptoms. And so you just wonder why we're 5 series of injections done on his lumbar spine, and they didn't identify that in the first place. So it can be quite important to do that. Anything else on pain provocation? So overall, the validity of that approach is better than movement or positional faults. Can't say it's perfect, but it's clearly better. There are some peculiarities around it. Didn't say that word very well. Peculiarities? No, can't say it. But we'll talk about those more when we demonstrate the tests.
Sure.
And in terms of the reliability and validity of, reliability of these tests, when you look at the individual tests, they do tend to be a bit better than the individual movement and positional fault tests. But when you use the whole paradigm that Laslett used, then it's significantly better. All right, I did say we would come back to hormones. So here we have, and this this is a diagram I made a long time ago, actually, 2007. So this is just to pretend that we actually know what we're talking about, because I've quoted one of the paper I was involved with here.
Looks impressive.
It does. So there is this thought that increased relaxin during pregnancy increases your laxity, and that results in pain. Bang, bang, bang. But it's not that clear. So there's many studies that have looked at relaxin levels and tried to relate that to the amount of pain, and none have. Yeah. And actually, within those studies, what they find is a more reliable indicator of pain is the active straight leg raise, which has nothing to do with movement in the pelvis, so to speak, or in the sacroiliac joint. So we'll cover that at another time. So there's really this mismatch between what the research tells us on relaxin and what many clinicians believe.
Is that saying that hormones aren't relevant to sacroiliac joint pain?
No, not at all, and that's what this table's all about. And
I haven't read it, so you might want
why not?
give me the quick summary.
Why not, Tim? Well, it was interesting looking at this table. You know, now we're in 2020, so 13 years later, and actually there's more focus on hormones and inflammation and things like that in pain disorders. So I've got 4 things here. One is around altered collagen synthesis. So there's no doubt that hormones do play a role in that. But just because you're changing collagen synthesis doesn't mean there's going to be more or less movement in the joint. But it could affect its ability to take load. But more commonly, hormones are a direct mediator of inflammation. And clearly many of these women during pregnancy that have severe symptoms present as if they have a severe inflammatory disorder.
Okay.
Think of the ones that are in wheelchairs because they can't walk.
Sure.
Yeah.
So arguably the hormones bit there is more around possibly other mechanisms for pain sensitivity rather than relaxin causing the pelvis to be loose.
Yeah, and that could be mediated by inflammation or directly by modulation of neural activity in the periphery, resulting in peripheral sensitization.
Okay.
And there's a whole other role of hormones in kind of development, but it's not so relevant for what we're talking about now, so I probably shouldn't have mentioned it. But hormones are clearly important, but the literature, the broad literature in pain really supports this inflammatory and neuromodulation rather than this old idea that we have to think about relaxin, increasing laxity, which, as we just discussed, doesn't really fit with the assessment paradigm's validity.
Yeah.
So back to this. So this is just for people to reflect on and think about their beliefs around these assessment paradigms. It's interesting, like some people can be confronted by this. It can be very confronting, particularly if you've invested a lot of time and effort into a singular approach. But for others, it can be very freeing. They've felt inadequate as therapists because they haven't been able to assess these. Yeah.
And I certainly remember that concept of me not being very effective, or as they say at the football games, you see what you want to see.
Yeah.
So trying to work out, hang on, I can't really pick this, and then having a more, what I think now is a very logical explanation for what's going along, or what's going on around the pelvis and where the source of symptoms potentially are, and the mechanisms. I found that definitely liberating.
Yeah, me too. Okay, so once again, we're open for questions. Got any more questions, Tim?
No, I'm done for now. We'll cover a few more topics a bit later on, but be interested if people do have some specific thoughts or questions around that. Because when we teach physios and health practitioners on this, the similar types of questions that we've tried to address here often come up.
Yes.
But that's okay. It takes time to sift through this stuff if it's foreign to what you're used to, or it's a different way of looking at it, I think.
Yeah, and I think often people are scared to speak up in a class environment. So that way you could, if you email us at education@painoptions.com.au, instead of abusing you in front of people, we can abuse you by email.
Very nice.
No, we wouldn't do that. So this is a reminder that there'll be more upcoming episodes. the next one we'll start to look at the subjective assessments. So I'm really interested to hear your thoughts on that. And again, I think hopefully this has helped people's clinical reasoning, and we'll see you next time.
Cheers.